Hi, everybody. Welcome to the Shout webinar number 7. We're just going to give everybody another minute to join us, and then we'll go ahead and get started.
All right, good afternoon, everybody, and welcome to webinar 7 of the Shout series. My name is Hannah Snyder, and I'll be starting off our presentation today. So I'll get started by introducing Shout. Shout is a joint collaborative between the California Healthcare Foundation and the University of California, San Francisco. I know many So what we are is a collaboration between hospitalists and maternity care providers across the country who are working together to increase the access to opioid agonist therapies, buprenorphine or methadone, in the inpatient setting. Using this opportunity of a hospitalization to really get people stabilized, started on treatment with either methadone or buprenorphine, and then connected to outpatient treatment. I think this can be an invaluable opportunity for people to really enter recovery from the inpatient setting. Shout has a few different things that we offer. You are here for our webinar, so you are aware of our webinar series. I'll point you to, on our final slides, there's a link to where all of our webinars to date have been recorded. In order to get things off the ground at your hospital, there's no need to watch all 7-hour-long webinars. However, they can be incredibly useful if you have specific questions. We brought quite a few different experts on our panels to date. We also make available through our Google Drive our guidelines, a toolkit, which includes perioperative and acute pain management guidelines, as well as initiation guidelines, patient handouts and frequently asked question sheets, and some of the nitty-gritty things that you need to really get buprenorphine or methadone off the ground at your hospital, such as a P&T committee monograph sample template that you can use. We also offer interactive monthly coaching sessions, as well as in-person site visits and grand rounds. That's something that would be helpful to get these services started at your hospital. Folks who've been with us from the beginning started with us in November, although everyone is welcome to join us at any time in the series. We originally had our didactic webinar series, which is now completing, and folks who've been working with us worked during that time to build a team of stakeholders, gain formulary approval for buprenorphine, and get their hospital administration on board. Now here in February and March, we're doing our last webinar on breaking down some of the barriers that folks face to inpatient implementation of buprenorphine and methadone. And we're seeing that some of our participants are now starting to actually pilot the use of buprenorphine in their individual hospitals. We're really looking forward to April and May, where our didactic series of webinars will have finished, but we'll really be ramping up our efforts to get things off the ground at your individual hospital. We are offering an in-person workshop, which we really recommend that you come to, on May 4th in Oakland at the California Healthcare Foundation headquarters. And that's an open invitation to anyone who's involved in an in-hospital rollout of buprenorphine or methadone. We'll talk a little bit more about that at the end. And then if anyone is in need of site visits, grand rounds, or any kind of ongoing coaching, we are happy to provide that in the next several months. With our goal really of having people do a full rollout of starting buprenorphine and methadone in the inpatient setting by about June. If anyone has any questions or concerns about this along the way, shoot us an email and get in touch with us, and we'll be happy to have a one-on-one meeting. We are additionally offering group coaching calls, which I think folks have found very helpful to date. It can be really great to have a group of all of the California urban hospitals or all of the California rural hospitals, that people can bring up individual barriers their hospital has been facing, and the group can kind of troubleshoot en masse. We're finding that one hospital's experience has really been able to inform other hospitals in the group, and we recommend that you join us on these upcoming calls. You should be receiving invitations to participate in these upcoming calls, but if you're not for whatever reason, again, let us know and we're happy to share that with you. Today, we're really excited to have a special panel on telemedicine. And I want to introduce just a couple of our guests and then introduce the topic as a whole as well. Our panel is somewhat large today, but just to review a couple of the individuals we have with us. We have Jonathan Ciampi, who's the CEO of Bright Heart Health. He's joined by a couple folks who've worked with him, Christy Waters and Reb Close, who are both doctors who work closely with Bright Heart, as well as Casey Grover. Reb Close and Casey Grover are both actually emergency room physicians at Chomp, who have been working with Bright Heart Health to do telemedicine implementation of buprenorphine inductions in their emergency room. We're also lucky enough to have, as part of our panel at the end, James Gasper and Kristen Harder, both of whom are expert pharmacists and really familiar with kind of the, not only the pharmacology of buprenorphine, but also just the logistics of how one is able to get this off the ground and running at their hospital. So we'll invite you to give any questions that you have, type those questions into the Q&A box throughout the presentation, and all of our expert panel. I'll just start by doing a little bit of an introduction, and then Jonathan and Reb will give you a case study of how telemedicine can be integrated into your individual practice. At the end, we'll leave at least 10 minutes for questions and answers. So again, please type in your questions in the Q&A box throughout. All attendees are going to be muted throughout this presentation, just so we don't have too much chaos in the background. But you can either chat to us or use the Q&A box if anything comes up that you want to make sure gets addressed. We'll make sure that this session is recorded and will be posted on our website along with all the other recordings at tinyurl.com/projectshout. And you'll see at the bottom of your screen, this is a new format for some individuals. There should be a bar. If you hover over the very bottom of your screen, that should have a Q&A button as well as a chat button. Please feel free to use any of those to communicate with us throughout. Okay, so today we're talking about telemedicine, which is, I think, a very new concept for a lot of us as providers and a little outside of what we've done before. But in conversations that we've been having with individual providers at hospitals across the state of California, across the country, we've learned that a lot of the barriers that they're facing in terms of either inpatient or outpatient care with buprenorphine can really be broken down by accessing telemedicine. There are a few different methods that hospitals use to deliver their care for buprenorphine, and telemedicine is one of these. So the first model, and the model that the majority of Project Shout has actually been based on, is just training all hospitalists or all maternity care providers to be comfortable with doing buprenorphine and methadone inductions. We think this is a realistic goal for a lot of individuals and a lot of different hospitals. Certainly at San Francisco General, where I work, this has been our standard of care. It's true that many hospitalists won't be completely familiar with doing buprenorphine starts early in their time with this, and so there are backup resources available. An organization called PCSS MAT provides mentors who are able to serve as kind of backup, as well as the UCSF CCC substance use warm line, which can be called during business hours, 9 to 5, Monday through Friday, can also provide kind of clinical assistance and support with any clinical situations that are confusing to an individual provider. We think the majority or many hospitals will actually be successful with this model of training all hospitalists. However, we know that this doesn't work for every hospital. A couple other methods that some of our participating hospitals have used is, one, just having a local expert available by phone. So many folks have trained their hospitalists to a basic level and then have a local addiction medicine doctor or a buprenorphine specialist who's available by phone to consult with their hospitalist when necessary. Some other hospitals have used an outside consultant who actually comes in person to the site. That can be an addiction specialist who visits multiple different hospitals, or one who simply serves that hospital and rounds, say, once a day or a couple times a week to support patients who are getting started on buprenorphine. The fourth and final option, though, that we want to offer to you is starting patients on telemedicine. We know this can overcome a couple different barriers to care. There are, in many communities, particularly in rural areas, really limited outpatient clinic locations, either for buprenorphine or methadone, and this can make it really challenging for our patients to access care. The limited outpatient clinic hours can also be an issue for many of our patients who are working in school or caring for children, and may lead to decreased rates of follow-up. And in addition, there's just long wait times often to enter into care, either with buprenorphine or methadone. And we believe that using telemedicine to connect patients to outpatient treatment can really surmount some of these barriers. The other barriers, though, that we often hear from our patients are a little less straightforward and can potentially also be addressed by telemedicine. So a lot of our patients have concerns about being seen at a clinic that is traditionally thought of as an addiction medicine clinic and don't want to be associated with that, or have concerns about substance use that can surround these clinics, or even drug dealing that occur near this clinic. Now, many clinics don't have these issues, but these are some concerns that we hear expressed by patients that can really be surmounted by using telemedicine. So telemedicine is one option. It is a really excellent option, but it is not the option that's needed for every hospital. We're really excited, though, to bring on Bright Heart Health and our local telemedicine experts to talk about how this can be integrated, and has been very successfully integrated at Chomp. There are many different organizations that offer these telemedicine services. Bright Heart Health is one, and they're one that we're very excited about. There's many other ones out there. And across the board, we find that these telemedicine organizations can ease the transition into treatment and can just really increase access for our patients. And that's the #1 goal of Project Shout. And so we're so excited to welcome them onto our webinar today. I'm going to turn it over to Jonathan and Red.
Great, thanks a lot, Hannah. I really appreciate it. And thanks a lot to Project Shout, Sarah, everyone's support. I've been promoting this a lot. I think the discussions that we're seeing happen throughout the country. And so we've invited a lot of people from across the country for this webinar because, to your point, Hannah, there's a lot of barriers that people are experiencing. And without having either local resources to rely on, or the hospital hasn't yet started using buprenorphine, it can seem like a challenge that's insurmountable. And so telemedicine is one option. So what we thought would be useful is to go through a case study, put it in the day in the life of a patient, put it in how Chomp is doing this. And so to get started, we'll talk a little bit about the problem. I mean, most of you are probably aware of the CDC report that came out recently indicating hospital admissions around opioid use disorder have increased significantly. We see it throughout California and the counties that we're working in with. And what's amazing with this is when we look at the patient population that we're working with and the challenges patients have getting into care, you often see the similar hurdles, whether it's, I can't find somebody who can provide this care, or I have this patient in the hospital and now I need to discharge them, but I'm running into problems with finding a local provider. We've already called 15, or they're only a cash pay clinic, or there's all these barriers that patients are running into. And if we go to the next slide, what we'll find is that the barriers create a lot of like compassion fatigue, one-on-one support mechanisms. Certainly it requires more resources, and it's a burnout factor. And no matter where you are, the problem is pervasive. And so telemedicine, providing MAT, allows not only the And I think it's important that when we think about MAT, and we can move on to the next slide for this, is that it's comprehensive care. We're not just talking about pushing medications out to the patients, but what we want to do is provide them all the care they need. And we do this through telemedicine. And that's a little surprising. And sometimes people scratch their heads. I was just talking to somebody who was running an emergency room, and they were scratching their heads, trying to wrap their head around, like, how does this work with telemedicine? So let me just try to verbalize how it looks to individuals. If you think about a comprehensive clinic, physicians, therapists, recovery, peer support, case management, all of these individuals are available to the individual through a device, whether that's a computer, tablet, or smartphone. And oftentimes people think, oh, well, devices and connectivity, that's a barrier. But what you find out is that that's really not a barrier much anymore. In fact, we work at several homeless shelters, and we consistently ask the executive directors, how much of your population has access to smartphones and connectivity? And they'll tell us easily 90%. There's lots of programs out there to support connectivity. And so what we see is this pervasiveness of access to care through telemedicine. And so in our goal of providing MAT, we wanted to make sure that the care was comprehensive. So when a patient is handed off, all of the other issues that will be needing to be addressed can be dealt with, and that they're getting the support they need so they can be safely in recovery. So let's go ahead and move forward. And Reb, I'm going to ask you to start jumping in here, because Chomp is a community hospital of Monterey Peninsula, which Reb can go through, is one of the first hospitals that we started working with. And it was important when we were getting up and going that there were a few things that we could provide to them. One was 24-hour access, and two, that they knew that when they made the handoff, that it was sure that the handoff was received, and that we would be able to communicate back to them on what was happening with their patients. Reb, do you want to give a little background on Chomp and what the history was before we came in, and then how we got started? Reb, go ahead and unmute yourself there.
So this is Casey. I'm also community hospital. It sounds like Reb may be having some technical difficulties.
Thanks, Casey.
John, can you hear me okay?
Yeah, you're coming through great.
Great. So the history of community hospital of the Monterey Peninsula is that we previously had a very robust chemical dependency program in which we were using predominantly intramuscular buprenorphine to manage withdrawal. And we had a pretty expedited and streamlined referral process to a local addiction treatment program. And for various reasons out of our control, access to that addiction treatment clinic stopped, more or less. And so what we were finding is people were coming into the ER for buprenorphine, and we just had nowhere to send them. So we had to come up with new pathways that didn't involve buprenorphine, clonidine, tramadol tapers, not quite as ideal. Because unfortunately, we had nowhere to send patients. And so it's actually been extremely practice changing for us now, knowing that we can regularly use buprenorphine for the stabilization of opiate dependence and withdrawal, because Bright Heart gives us the option to guarantee that we can get every patient or Medi-Cal, you could not. And it's not to say that we only select certain insurances to go to Bright Heart, because there are other people who, for certain reasons, prefer telemedicine, maybe because of the fact that they don't have to go to a clinic, or they can do it on a more private basis. But really, Bright Heart basically gave us the opportunity to start using buprenorphine in the emergency department again.
Yeah, and I think that's really important, Casey, is one of the things that we had a conversation about early on was that there wasn't going to be this, what I call the cherry picking of patients. You had to have the access for everybody. And so that's important that all forms of insurance were acceptable, as well as making sure that you had immediate access, meaning that you weren't going to refer someone and there was a long waiting list or some other barrier that would activated to get that follow through.
Yeah, and this is Reb. I think I'm unmuted now.
Yes.
Good job, Reb.
Okay. Perfect. Thanks. So yeah, to reiterate with Casey, we had a beautiful program in the past where we could get people followed up. All of our docs were comfortable using buprenorphine and getting people started because we knew we had follow-up. And then when that was taken away, you take a group of emergency physicians who have seen the effectiveness of buprenorphine and of recovery and referral, and you take it away from them. And we literally were beside ourselves. And I'll have to say I was so tremendously fortunate to run into Dr. Khan at a meeting, and I expressed to him my frustration with having been able at one point to provide care to patients that was subsequently taken away from my option for them. And that's when we started talking about Bright Heart. And that was part of the reason that our hospital was so welcoming to this, is because we knew how well it had the opportunity to work for our patients and community.
And John, just to echo on the point that you made, that you weren't going to cherry pick patients, that's really an extremely key point, meaning that everybody has access. And I was working just a few days ago, and I had a woman who came in and was saying, I've called so many clinics and I can't get anyone who is willing to take care of me. And I was able to put her in contact with Bright Heart, and Dr. Waters was able to help me with some advice. And they're at a point where they're finally willing to receive treatment. And for some people, this is years in the making. And to be able to give them an option that they can count on in their crisis is invaluable.
And I think from our standpoint, when we were really working with you guys in defining this, because you were the first hospital we started getting going with, whether it was in the ED or inpatient, it really didn't matter. What I think was important, and correct me if I'm wrong, is you needed to know that, one, you could count on us and that we were available to you. And so I go back to that 24-hour a day, 7-day a week. So Casey, you just mentioned it. You had a question on a particular patient. You knew that you could get in touch with Dr. Waters, that she was able to assist you with that. And then the second piece is that because of telemedicine, it didn't matter if they were starting in the ED or they're in inpatient, wherever they are. The point is that the patient then has access. You don't have to call somebody and then wait for them to get a free moment in their schedule and drive a half hour to you. It was really that it was always available for you.
Yeah, absolutely. That has been one of the greatest keys for this. I mean, as ER docs, I mean, Casey and I both work, as we affectionately call ourselves, we're pit docs. You work in the pit. And it's all hours of the day, anytime, any situation. And to have that option, it's similar to how we look at poison control. You know, California has this amazing poison control center that you can call at 3 a.m. and ask for help. And it's a similar thing. We do respect that Dr. Waters is episodically able to sleep, and we're very respectful of that. But we really try to have that, look, it's the middle of the night and the patient needs help now. I know, and so now that Casey and I become more familiar, we're both very comfortable starting an induction process in the ER, knowing that first thing in the morning, this person's going to be basically open arms. Even if it is 3 in the morning when we start it, they're going to have open arms into recovery plan. And so it makes it so rewarding as an ER doc when somebody's there and they're so fragile and they're so scared, is to say, I've got you. We'll take care of this. And that's something I rarely get to say in comparison to other patient populations.
Yeah, it's great. Well, let's move on. Let's talk about the implementation here. So when we got started, I think there were a few keys to success that I learned, and really, Reb and Casey, to both of you. The first one is the most important, which is just a champion. Somebody who's it's always behavior change that seems to be the hardest part, right? You want to put something else into the ER or into the hospital, and it's getting them to buy into it and thinking about it. And that's where you guys came in. Do you want to comment on that?
Absolutely. So in our department, we have basically several physicians who have taken on addiction and chemical dependency as a niche. And in our department, it's Dr. Close and myself. And with that, it's great to be able to be kind of the troubleshooter, and also to be the local resource when folks have questions. And also just to promote the use of the service on a continual basis with success stories. And when colleagues are frustrated, you have an answer for them that is useful. The other thing that I will also mention with this is that, in general, this is not just for addiction. A champion really helps move forward. For example, our hospital is about to move forward with Epic, and our Epic champion is going to be the one that really helps us to move forward with Epic. And it's the same thing with, cardiology. We have our cardiology champion. And just as much as addiction is like any other illness, having Dr. Close and myself be the champions for our department really, I think, was a major factor in us moving forward, mostly because people were saying, wow, how were you able to take care of that guy? And we're like, let me show you. Let me pull up the Bright Heart website. Let me show you the referral form. Let me show you the process.
And if I may, there's also the fact that physicians are busy and we're simple people. And if we drilled it down, as it mentions on one of I think the later slides, is we drilled it down and said, this is what you do. This is who you call. These are the people that will back you up. This is the way to get started. And we literally just laid it out for our docs. And then we also do have a case management team. We laid it out for them. This is who you call. If you get a referral at 3 in the morning, I need you at basically 7 or 8 o'clock. You need to be closing all of these loops to make sure this person gets taken care of. And so we started streamlining that and just really pulling people together and not having them figure out how to do it, but giving it to them of how we are streamlining the process.
And I think that's a good point, is with your case management team, as well as with you, one of the feedback loops we have is what happened with the referral and what was the follow-up? Did they attend the first appointment? Are they still in treatment? And that referral loop from our side certainly has been invaluable, because I think it helps create buy-in from you, but also shows you that we're responding to the patients that you're trying to send over to us. But it also seems like it's been helpful from your side in getting buy-in. Is that correct?
Oh, absolutely. Yeah, because I can tell my doc, this patient will be taken care of. If you are worried that they're going to go into the ether, as we describe it, that where we have no idea what follow-up happens, nothing happens, that's not what we're doing here. I have a warm handoff. I have someone ready to take this patient and take care of them. And my docs have a complete buy-in for that, because that's what we want as ER docs. We want to make sure that our patients are taken care of and that we're not just wishing them luck and hoping they somehow land in a good place.
Yeah, and when people are skeptical, showing them consistency does wonders to get them over their skepticism.
Very well said. Okay, well, let's go on. The next slide kind of is one of those that you can't always obtain it or attain this, but it's great, which is going through the case study, but also the success rate. We've talked about this. We put this in effect back in May, and we've now sent at least 25. I think now we're even over 30. And we have 100% attachment rate, which is great, meaning that they've come into program, they've had their first appointment. So we designed this after the Gail D'Onofrio study done out of Yale, which showed that starting buprenorphine increased their retention and treatment. We're seeing that approved upon here at Chomp. Let's go through a day in the life. So Reb, why don't you take it? You just had this. This is very recent, right? This was one that we just did.
Yeah. So I was working a shift on a Friday, and it was Friday afternoon, evening, and I had 2 ladies, and both of them were late 30s, early 40s. Both of them were in the ERs with their kids. And these were adult children that were there trying to support their mothers as their mothers were in the emergency room in crisis. And and both cases were very, very powerful for me as an ER doc, and as well as a mother. Is to look in the eyes of their children and say, okay, I can help your mom. We can do this. Moms were both desperate for help, both very much in withdrawal and very sick. So what we've decided, like I said, if you make things easy for docs, we're much more compliant. And so I did 8 milligrams of bup in the ER orally, sublingual, and we waited. And I came back 15, 20 minutes later, checked on the patients, both doing a lot better. They'd had time to talk to their daughters. We were coming up with a plan, grabbed, for one of the patients, I was able to grab my social worker because it was during their hours. The other one was later. And we wheeled the computer on wheels in the room. They started getting registered with Brightheart. I think the other one used her phone. And we literally got them hooked up, had appointment next day, ready to go with Dr. Waters. And I think one of these patients I was able to know that I spoke with her, and I think the second one I just referred because I knew it was going to work. We had it taken care of, and my ladies are following up. And as far as I understand, my social worker followed up with me recently about them, and we are moving forward with making sure they continue their recovery and haven't fallen away from getting the care they need.
Yeah, so this is give her side of this case study. Dr. Wires, did you want to comment on these cases?
Sure. Both these ladies are still in treatment. We're moving on to week 3, and I know that we don't put this on the chart, but the relationships with their adult children have improved 100%. So that's really important. Both these gals were estranged from families, estranged from grandchildren. One was close to becoming homeless because of this, and the other was struggling to stay in school. So both of these ladies, when I saw them for the appointment, they both were a little surprised that they weren't sicker. One of the reasons they had hesitated about treatment is that they thought they were going to have to go through days and days of hard withdrawal, and they were not looking forward to that and kept negotiating, putting that off. But getting medication in the ED, being treated by a physician who understood what was going on and could tell them what to expect, myself over the video screen. And so they were already on buprenorphine. I could give them more information about side effects, do an assessment about where they were in their withdrawal, adjust the dose a little here, a little there. One family stayed in the background and actually participated off screen about this. And again, that's a really nice bonus when we're using telemedicine. And both ladies were able to get their questions answered. I was able to find a local pharmacy to continue their buprenorphine. Told them I would be calling them in 24 hours and that they would be meeting with their individual therapist within the week. And they were extremely grateful that they could do this from the privacy of their home, feel respected, feel like full-grown adult women, and that they had never been treated like this before around the issue of their substance use. And I think that that part probably does more than just the medication by itself. So they're both doing really well, and one recently got 80 plus on an exam at school, and she hadn't done that ever. And her teacher pulled her aside and said, "I don't know what you're doing, but keep it up." So
Yeah, that's really good. And then, I mean, one of the comments that you said, and it's just a build off of Dr. Grover's comments earlier, which is the consistency. I mean, Dr. Grover was referencing the other physicians, but it works just as well with the patients. They hear from the emergency room physician, here's what's going to happen, here's what you're going to do. And then they come into treatment and they're hearing the same story and all of their providers are speaking the same language. They're all laying out the path ahead of them, which makes it a lot easier, especially when you know it's chaotic in their mind as to what's happening, and there's a lot of fear or trepidation, that this consistent message is constantly being communicated to them. So let's go ahead and go on to the next slide. Yeah, takeaways. And I think we heard this, whether it's telemedicine, Dr. Herring talked about this on the previous webinar at Highland Hospital, where he's using a BIC, which is a buprenorphine induction clinic. They've got a SUD program, and then telemedicine, MAT. I mean, we're removing barriers. It seems like that's the most important thing. And when we think about telemedicine, we really want to remove all of the associated barriers that prevent care. And I believe, obviously I'm biased, but telemedicine affords the opportunity to reach patients at a particular time that traditional in-person programs that may not be able to. So what we're seeing is geographic barriers, hours of operation, time to appointment. These barriers are removed and access to comprehensive care is available. And the easier we make this, the more that we remove the reasons why people don't go into care. And what we like to say is that the only barrier is motivation. And I think, Reb and Casey, you guys would say the same. I mean, basically, we've taken away all the other impediments to treatment.
Oh, 100%. The fact that I can refer anybody, it doesn't matter insurance, it doesn't matter. The fact, because I'm an ER doc, my consultants will ask me all the time, I'll call a surgeon to try to get someone into an outpatient clinic. What's the patient's insurance? I don't know. I mean, to be honest with you, I'm an ER doc. We see everybody, anybody that needs us, we see that person. And truly, that's what Bright Heart has made possible for us, is that if I have a patient, it doesn't matter any of the logistics. If they want help, I can give it to them. And so breaking down the barriers, that's the answer. It's just there's nothing except the patient's motivation. Exactly what you said. If they're not ready, I can't do it. But if they're ready, I just tell them, we've got you. We will take care of you. And I can promise that because we do.
Yeah, it's comforting words, and it really helps a lot. So that's fantastic. And I think that's the point at which we'll leave it. I mean, I think it's now open to questions, but I think the point is that whether it's inpatient or emergency department, doesn't really matter the venue. It's more that the services are available, and they're available no matter where you are, any time of day. And it's a comprehensive team that can support that, both the providers such in the hospital or the patient. So Sarah and Hannah will now open it up to questions.
Apologies, I had muting issues again. So we've got some great questions coming in. Thank you so much, everybody, and please continue to input them into the Q&A slide. I'm actually going to just jump right into the questions a little aside from our normal format, and so that we can get all of these great questions answered. So if someone from Bright Heart can comment on what counties are you currently approved for practicing with Medi-Cal or Medicaid patients in?
Yeah, good question. So I'll take that one. So we are a fee-for-service provider directly to the state. We don't have to go through the county, so we can operate in all of the counties across California. We also operate across multiple states, so anyone who's outside of California, that's available as well. But yeah, so that we're not on that county restriction. So it's a good question.
Great. And then wondering if someone can comment on what happens if a patient does not have insurance, if there's an uninsured patient.
Yeah, I'll take that one as well. For California, and this is true in other states, but I won't speak to the other states. So California specifically, there's a hub and spoke grant. It's the STR opioid grant for uninsured patients. We were a recipient in 5 counties. That would be the Sonoma, Lake, Yolo, Colusa, and Napa counties. There are also hub and spoke recipients throughout different counties, and we will work with them. If it's through Bright Heart Health, we will work with them, but there's also the hub and spoke, and you should reach out to them because they have grant dollars for covering uninsured patients. So without insurance, they should be covered. And it covers, and I want to comment, it covers uninsured as well as underinsured. So these people with these incredibly high deductibles who can't afford to pay for treatment out of pocket, that it's going to cover those as well.
I'm wondering if someone can comment on how telemedicine has been dealing with HIPAA and protected health informational requirements, and specifically how this has been playing out for you all.
With our platform, we're using encrypted video technology. So it's always, think of it as synchronous, meaning that I have two-way audio video. I'm seeing the patient, I can hear the patient, it's all together. That's all encrypted. But really where you get into the HIPAA issue is at the other end. So who's around the patient? Are they in a confidential area? Are you able to see people on the screen? So within these technologies, you have the ability to actually remove them from a screen. So if you're doing like a group setting, you can remove individuals so that way the screen is turned off. But what we require, and this is the recommendations if you look at any of the distance counseling or telemedicine standards, is that patients are wearing headphones. And that's important because what you're really wanting to do is protect that conversation. And if they're wearing headphones, then you know that you're having that conversation and people can't be eavesdropping. And that's really what you're looking for. Around the other PHI information, medical records and all of that, I mean, you heard Casey talk about Epic, lots of EMRs out there. And a lot of EMRs are now building telemedicine into their platforms. And so you can use those to ensure PHI and HIPAA compliance.
Great. So we're getting a few questions about other venues in which Brightheart and telemedicine work. So we've been talking a lot about starting patients in the emergency room and then transferring from there. Wondering if you can comment on how this would work in the inpatient setting or the outpatient setting and other avenues through which patients can enter your care. Yeah,
so I'm going to go ahead and let David Kahn's on this one. I'm going to let him take that one.
Hi, sorry about that. David Kahn, I'm the medical director of Brightheart Health. So there's the emergency departments. We also work with federally qualified health centers, community health clinics. Just looking at the questions as they scroll past, we have contracts and venues that are not typical within healthcare. We work with homeless service centers. We are working with the CDCR, the California Department of Corrections and Rehabilitation. There was a question about working at a syringe exchange program, and we would love to do that. Essentially, with telemedicine, we are allowed to provide treatment where the patient is, where the client is, and we don't want to set up, again, it's what John said, we want to limit the barriers as much as we can.
Great. And so what would that look like if a patient was admitted to an inpatient service and then started on buprenorphine in that setting?
So we could then take the patient upon discharge. So it could be that the social worker gives us a heads up, calls the number and says, hey, we have this patient on buprenorphine, would you be willing to accept them? And then we'll set up an appointment to meet face-to-face with the physician shortly after discharge, if it's a planned discharge. And with some hospitals, as we get credentialed, we can even begin the relationship within the hospital in the form of a tablet computer that we would give to the hospital itself. We have technology within our budget, within our grant budgets, and so if anybody wants an iPad for your facility, whether your setting, whether it's a syringe exchange program, whether it's FQHC or anything like that, we're happy to talk and get you the technology to connect with us.
So we have a clarifying question, which is, does the first encounter need to be face-to-face with the MD in order to prescribe buprenorphine, no matter where the face-to-face is?
Right. So where things are at right now is we have to follow the Ryan Haight Act. This is the Ryan Haight Online Pharmacy Act of 2008. And what the Ryan Haight Act says is that you must have a face-to-face encounter with the physician to prescribe controlled substances. However, there are exceptions. So if the person is within a DEA licensed facility, such as a hospital, an emergency department, or something like that, we can do the initial assessment that way, but we'll make efforts to meet face-to-face to continue that. They can be in the presence of a DEA registered individual, such as a physician, nurse practitioner, or physician's assistant. So for example, if they're in the FQHC and the PA is there sitting with the patient as we're doing the telemedicine encounter, we could then prescribe there. We try to get face-to-face encounters so that we don't have to send the patient to near and far in order to be in the place in which they can receive the prescription.
And along those lines, we have some questions about the more physical aspects of an exam. So if the patient needs vital sign monitoring, if the patient needs urine drug screening, how do those things play out?
So when it comes to the physical examination, we'll certainly do that in a face-to-face visit. What we say is when in doubt, send it out. Though we're an addiction treatment program, we're really emphasizing that patients need to get a primary care provider to take care of their total health. The other piece of it too is that we need to make sure that they have coverage. So if we get an uninsured patient who's Medi-Cal eligible, we'll help them with the process. When it comes to drug screening, we can do that on camera. So for example, if they get a saliva drug screen. So we mail the drug screens to the patients, and with the saliva drug screen, you can literally do that on camera. So it's a cool application of technology. This is point of care testing, but if the person has an invalid or irregular results, we could always send them to the lab to get that done. And just like any sort of opioid use disorder assessment, we'll do the initial assessment and recommend the typical lab screening that goes with the patients.
Great. A couple more broad questions. We have somebody wondering if in California there's an age restriction for when we can start buprenorphine. What are the youngest patients we're able to treat?
I think in California, technically above the age of 12, the patient can consent on themselves. I've given talks about this, but I can't remember the exact date. Using buprenorphine in younger, like under the age of 18, I will say is a controversial area because these are adolescents that are still maturing and there may be still some role for detoxification. I would say that a lot of it depends upon the assessment. If the person's 18 and they've been injecting heroin for 4 years, or they're 17 and they've been injecting heroin for 4 years, I have to think that this is a patient for whom opioid agonist therapy is a more likely, we're going to do this perhaps with an eye towards tapering sooner. But there's frankly not a lot of good evidence what to do with adolescents. I think some treatment, any treatment, is critically important because we know about the rise of fentanyl across California and frankly across the nation. It's super dangerous, and we should get somebody into treatment and some type of medication to reduce the risk of overdose.
And this is Hannah Snyder. Just to comment, my understanding, and David, correct me if I'm wrong, is that buprenorphine is FDA approved for 16 and up, and that patients who are under 18 are able to consent for themselves for non-medication treatment. But on my last look, it seems like you do need parental consent for medication treatment.
Yes, yeah, you're correct, Hannah. Sorry about that.
Great. I see a question about whether or not an X waiver is indicated for buprenorphine for pain, and I can just answer this one. For pain indications, any prescriber is able to prescribe buprenorphine, including the patch. But for any opioid use disorder, they do need to go through the X waiver process. We have a question here for our folks from Chomp. They're wondering about the experience of initially losing your program and kind of what happened there and what were the limitations on your ability to treat prior to starting with Bright Heart.
Yeah, so we're a very special circumstance. So an addiction-trained family practice doc works in our ER. He's been there for a zillion years. And so he teaches us kind of on the fly. When I came to Chomp, I knew nothing about addiction treatment. EM residency, when I went through it, had, if I remember any training, I'm shocked. And so when I came to Chomp, he explained to me, okay, here's how things work. This is what we do. He taught me, and we've all kind of worked together. We're all in the pit, so to speak, together. And so he, as Bupe was becoming a medication that was more used, we were learning. And so he would teach us, okay, you know, give them 0.3, 0.6, see how they're doing. And it similarly, I didn't use propofol as a resident. And I learned it kind of on the job training as I learned how to use it and what to do. And it was the same thing with buprenorphine, but I truly had a mentor there in our department. Well, he also, because he's FP and addiction trained, he runs a clinic. And so, of course, because his expertise is intense and needed here, we could get them treated with bup in the ER and then refer them over to him. And so he would follow them as outpatients. So it was the ideal circumstance for local treatment, but there was an insurance change. And so what it was is the clinics, plural, that he was running as an outpatient, the Medi-Cal contracting went to a different program. And so he was no longer able to accept Medi-Cal. And it's exactly as Casey said, you cannot say to a patient, oh, you have great insurance. Okay, I'm going to offer you this somewhat miraculous treatment. Oh, you have either no insurance or a Medi-Cal insurance that's not accepted by the clinic. Yeah, I guess try to find clean needles. I have nothing to offer you. And so he helped us formulate a pathway that, frankly, I couldn't stand using with, you know, clonidine and Zofran and tramadol and all these other medications that have a lot of interactions and side effects, and frankly, were not as effective. But that's the best we had. So we went through, gosh, I want to say it may have been almost a year that it was, well, okay, we'll try this alternate pathway. Good luck getting in. So we were tapering people. So the pathway that we wrote was 5 days of tapering people off of all these other medications. And I never felt good about doing it. I felt like it was a disservice given what we had experienced before. And so when I approached Dr. Khan about it, I cannot feel good about what I'm doing when I know there's something so much better and safer. And so that's why we really started brainstorming fast.
Thank you so much. We've had a couple questions about the duration of time that we can anticipate relying on Bright Heart. So if there's grant limited funding that's time limited, or any other concerns along those lines in terms of the duration that this resource will be available.
John, do you want to answer that?
I believe he's off the call.
Oh, that he had to drop off. That's right.
Yeah.
So we have the grant funding is likely to go for 2 years. I think we're 7 or 8 months into the grant right now, so it's another year plus. As a company, we are running revenue neutral, meaning that even before we got the grant, we've been self-sustaining, and the answer to sustaining is, I think we're headed very much in that direction. So I can see us moving forward into the foreseeable future. California has signaled a strong intent to continue the Medi-Cal expansion. And so when it comes down to it, I can see this not just because of the grant that we can do a lot of this stuff, but the grant provides a foundation that will then, we describe it as an accelerator. So it's likely to be into perpetuity.
Great, excellent. I believe that's all the time that we have for questions today. Thank you so much, everyone, for putting in so many excellent questions. If we can advance the slides, I'm just going to make a couple more shout-related announcements. So we've posted here the email addresses. If you go back one slide, we've posted the email addresses of all of the presenters on the call today. Please feel free to reach out to any of us. We are all very eager to talk to you about what's been discussed so far today. We also posted, again, just in the meantime, before you sign up for telemedicine, if you do have any questions or concerns clinically, please go ahead and reach out to the UCSF clinician consultation line or some of the other resources that we pointed to earlier. Advance, please. We have put 2 different websites down here. You can see the tinyurl.com/Project Shout has all our recorded webinars, as well as the Shout Share link brings you to our Google Drive. That link has all of the guidelines, all of the materials we produced to date, and really everything you need to get a program like this off the ground and running. We're asking everyone who's working on implementation at this time to please fill out the needs assessment so we can make sure that we're providing everything that you need in the next month going forward. It's really going to be a collaborative workshop for most of the day. Come and go if you need to, if you're unable to stay for the full day. But it'll be a great time to discuss any barriers that you've been facing, kind of get into the nitty-gritty of developing workflows for your own individual hospital, and then attacking any barriers that you might be anticipating. If you want to register, you can see our link there is below, and these slides, again, will all be posted online if you'd like to refer back. And then we will be sending an email with the follow-up PDFs and PowerPoints, as well as the webinar recording. That will come together with both the needs assessment link and also a link to a survey. As today is our last webinar, we really do want feedback on how these webinars have been for you, if they've been helpful, and if they've changed your practice at all. Thank you so much for joining us today, and thank you so much to the team from Brightheart and from Chomp. This has been incredibly informative and is an incredibly useful resource for all of us to take advantage of. Thanks very much and have a great rest of your day.
Thank you.
Thank you.